explain how the principle of patient autonomy influences the process of obtaining informed consent, include how to handle a situation where the patient refuses a recommended anesthesia plan. Answer: patient autonomy is a fundamental ethical principle that ensures individuals have the right to make decisions regarding their healthcare. Informed consent is an essential part of this process where the healthcare provider must communicate relevant information about the proposed treatment, including risks, benefits, and alternatives. When obtaining informed consent for anesthesia, the CRNA must ensure the patient fully understands the procedure and is making an informed decision without coercion. If a patient refuses a recommended anesthesia plan, the CRNA must first ensure the patient is competent to make decisions. If the patient understands the implications of their decision, the CRNA should discuss the potential risks of refusal. For instance, refusing anesthesia for surgery may increase the risk of pain, complications, or even death. Despite the recommendation, if the patient persists in their decision, the CRNA must respect their autonomy unless there is an immediate risk to the patient or others. Documenting the refusal and any discussions is crucial. In cases where there is uncertainty about a patient's decision-making capacity, a second opinion or ethics consultation may be necessary. Under what circumstances can a CRNA be held liable for malpractice, and how can they reduce their risk of litigation? Answer: a CRNA can be held liable for malpractice if the following elements are established. Duty of care. A CRNA owes a professional duty to the patient. Breach of duty. The CRNA fails to meet the standard of care in their actions. Causation. The CRNA's breach directly causes harm to the patient. Damages. The patient suffers physical, emotional, or financial harm as a result. Malpractice can arise from errors such as administering the wrong drug, failing to monitor the patient adequately, or not informing the patient of anesthesia risks. To reduce litigation risk, CRNs should adhere to the AANA standards for nurse anesthesia practice and state regulations. Proper documentation of all procedures, patient interactions, and informed consent is critical. Clear communication with patients and the healthcare team can prevent misunderstandings. Additionally, CRNs should maintain competency through continuing education and skills assessment. Finally, CRNs should implement best practices for patient safety and participate in quality improvement initiatives to ensure safe and effective care. Dr. Alicia, a CRNA, is caring for Mr. Rodriguez, a 70-year-old with advanced dementia. His legal guardian insists on using general anesthesia for a minor procedure despite its significant risks to Mr. Rodriguez's cognitive and physiological health. What ethical steps should Dr. Alicia take? Answer: Dr. Alicia must balance patient autonomy with the ethical principles of beneficence, doing good, and non-maleficence, avoiding harm. While Mr. Rodriguez's legal guardian has the authority to make decisions, the CRNA must advocate for the patient's best interests. Dr. Alicia should first ensure the guardian fully understands the risks of general anesthesia, especially its potential cognitive impacts on a patient with dementia. Discuss alternatives. Present safer alternatives like regional anesthesia if feasible. Provide education. Clearly explain how the risks of general anesthesia, including postoperative cognitive dysfunction, may exacerbate Mr. Rodriguez's condition. Consult with the ethics committee. If a disagreement remains, seek an ethics consultation to evaluate the best course of action. Document decisions. Keep detailed records of all discussions with the guardian and healthcare team. By taking these steps, Dr. Alicia demonstrates adherence to ethical principles while respecting the guardian's legal authority. Ultimately, Dr. Alicia must ensure that the decision minimizes harm to the patient. How does renal dysfunction affect the pharmacokinetics of commonly used anesthetic agents? Discuss considerations for induction and maintenance of anesthesia in these patients. Answer: renal dysfunction can significantly impact the pharmacokinetics of anesthetic agents, particularly those metabolized or excreted by the kidneys. Drugs such as opioids, e.g. morphine and muscle relaxants, e.g. pecuronium, may accumulate in patients with renal insufficiency, increasing the risk of prolonged effects and side effects. For induction, propofol is often preferred because it is primarily metabolized in the liver and its clearance is not significantly impaired by renal dysfunction. Thiopental, on the other hand, is also liver metabolized but may still require careful dosing in renal patients. During maintenance, agents like isoflurane and sevoflurane are commonly used as they are excreted via the lungs, not the kidneys. However, muscle relaxants such as pancuronium should be avoided or used with extreme caution due to prolonged action in patients with renal impairment. It is crucial to monitor renal function preoperatively and adjust drug dosages accordingly. Monitoring creatinine levels and urine output is vital. Additionally, maintaining hydration and avoiding nephrotoxic drugs are key management strategies. What are the key anesthesia considerations for a patient receiving cisplatin-based chemotherapy? Answer. Cisplatin is a chemotherapy agent known for its nephrotoxicity, ototoxicity, and neurotoxicity, all of which require special anesthesia considerations. Nephrotoxicity. Cisplatin can impair renal function, leading to delayed drug clearance and increased risk of renal failure. Preoperative hydration is critical to minimize this effect, and nephrotoxic agents should be avoided. Ototoxicity. The patient may have hearing impairment due to cisplatin. Avoid aminoglycosides and other ototoxic drugs and assess hearing function preoperatively. Peripheral neuropathy. Cisplatin can cause sensory neuropathy, making proper positioning during surgery essential to avoid nerve damage. During anesthesia, use drugs with minimal renal metabolism, e.g. propofol, and adjust the dosages of muscle relaxants and opioids based on renal function. Continuous monitoring of renal function and careful management of fluids are essential throughout the perioperative period. What legal requirements must be fulfilled for obtaining informed consent in anesthesia practice? Answer. The legal requirements for obtaining informed consent in anesthesia practice are essential to ensure patients' rights are respected and to protect healthcare providers from liability. These include disclosure. The CRNA must provide the patient with a clear explanation of the proposed anesthesia, including the type, risks, benefits, alternatives, and potential complications. Competence. The patient must be mentally capable of understanding the information provided and making an informed decision. This requires assessing the patient's cognitive ability. Voluntariness. Consent must be given freely without coercion or undue pressure. Documentation. Written or verbal consent should be documented thoroughly in the patient's medical records to confirm that the process was carried out properly. Failure to meet these legal requirements may result in legal consequences, including malpractice claims. AANA standards emphasize ensuring that the patient is fully informed and understands the anesthesia process. What precautions should be taken when administering anesthesia to a patient with systemic lupus erythematosus, SLE? Answer. Patients with systemic lupus erythematosus, SLE, require careful perioperative management due to their increased risk for cardiovascular, renal, and pulmonary complications. Key precautions include cardiac assessment, SLE. Patients may develop pericarditis or valvular disease, so a preoperative echocardiogram may be warranted. Careful monitoring of cardiac function during anesthesia is critical. Renal function, SLE, can lead to renal involvement, including nephritis. Anesthesia agents that are renally cleared should be used cautiously, and renal function must be monitored closely. Steroid use. Many SLE patients are on chronic corticosteroid therapy, which can suppress the adrenal glands. Steroid supplementation may be necessary during surgery to prevent adrenal insufficiency. Moreover, since SLE is associated with autoantibodies, patients may have an increased risk for clotting disorders. Ensuring appropriate coagulation profiles, e.g. PT-INR, apt at minimizing the risk of infection through antibiotic prophylaxis, are also essential. How can the implementation of a preoperative checklist improve anesthesia outcomes? Answer. Implementing a preoperative checklist is a vital patient safety measure that enhances anesthesia outcomes. A checklist standardizes procedures, ensuring that all necessary steps are completed prior to surgery, reducing the likelihood of errors. Key benefits include reducing human error. A checklist helps prevent omissions in vital tasks, such as verifying patient identity, reviewing medical history, and ensuring informed consent. Improved communication. It fosters better communication among the anesthesia team, surgical team, and nursing staff, ensuring alignment on the procedure and potential risks. Standardized procedures. By following a consistent process, CRNs can ensure critical steps like airway management planning or reviewing allergy histories are not overlooked. Evidence of safety. The checklist provides documentation of completed steps, which can be crucial in case of an adverse event. Studies have shown that checklists significantly reduce the risk of surgical errors, improve patient outcomes, and enhance teamwork, ultimately improving anesthesia care. Describe how the dose of anesthetic agents should be adjusted in the elderly population. Answer. In the elderly population, pharmacokinetic and pharmacodynamic changes impact the dosing of anesthetic agents. Common adjustments include decreased drug metabolism. Aging leads to a reduction in liver size and enzyme activity, which can slow the metabolism of anesthetic drugs. This necessitates a reduction in dosage to avoid drug accumulation and toxicity. Altered drug distribution. With aging, body fat increases and lean muscle mass decreases, affecting how drugs are distributed. Lipid-soluble drugs like propofol may have prolonged effects due to increased fat storage, increased sensitivity to anesthetics. Older patients may be more sensitive to anesthetic agents, requiring lower doses for the desired effect. This applies to agents like benzodiazepines and opioids, which can lead to prolonged sedation. To prevent adverse effects, CRNs should start with a lower dose, monitor closely, and titrate drugs carefully. Preoperative assessment of comorbidities, medications, and organ function is also crucial in tailoring the anesthetic plan. What are the potential risks of anesthesia in patients with pre-existing neurological conditions, and how can these risks be minimized? Answer: patients with neurological conditions such as epilepsy, multiple sclerosis, or Parkinson's disease are at an increased risk for perioperative complications. Risks include seizure exacerbation. Drugs like propofol and etomidate can lower the seizure threshold, which may trigger seizures in patients with epilepsy. Careful choice of induction agents and seizure prophylaxis may be necessary, worsening neurological deficits. Anesthesia can exacerbate conditions like multiple sclerosis, causing a flare of symptoms due to temperature changes or immobility during surgery. To minimize risks, a thorough preoperative assessment of the neurological condition is essential. Consultation with a neurologist, using regional anesthesia when appropriate, and avoiding triggers like certain anesthetic drugs can help mitigate these risks. What are the primary mechanisms of increased intracranial pressure, and how does anesthetic management mitigate these effects during surgery? Answer: increased ICP occurs when one of the brain's components, brain tissue, blood, or CSF expands and causes compression of the others. The Monro-Kelly doctrine dictates that the total volume of cranial contents is fixed, so an increase in one component necessitates a compensatory decrease in the others. Primary mechanisms of ICP elevation include cerebral edema, increased blood volume due to hypercapnia, and obstructed CSF drainage, hydrocephalus. During surgery, the goal is to manage these mechanisms to maintain adequate cerebral perfusion. Anesthetic management involves several strategies. Hyperventilation induces vasoconstriction, reducing blood volume and ICP. Hyperosmolar agents, e.g., mannitol, hypertonic saline, draw fluid out of the brain tissue, reducing edema. Head elevation and neutral neck position facilitate venous return, helping decrease ICP. Propofol and barbiturates are preferred anesthetic agents as they reduce cerebral metabolism and ICP. Avoidance of agents like ketamine that can increase cerebral blood flow and ICP. What are the critical postoperative monitoring priorities for a patient recovering from intracranial surgery? Answer: complications from raised ICP, neurological deficits, and respiratory distress, neurological monitoring. Frequent checks of the Glasgow Coma Scale (GCS) to track consciousness levels and assess for signs of neurological decline. Monitor for focal neurological changes such as limb weakness, speech impairment, or visual disturbances. ICP monitoring. Maintain a head elevation of 3045 to promote venous drainage and prevent increased ICP. Watch for signs of raised ICP such as Cushing's triad, bradycardia, hypertension, irregular respirations. Airway and respiratory care. Ensure adequate ventilation to prevent hypoventilation, which can lead to hypercapnia and increased ICP. Be vigilant about aspiration risks in patients with reduced consciousness or impaired gag reflex. Fluid and electrolyte management. Maintain fluid balance to prevent hyponatremia or hyponatremia, both of which can exacerbate brain swelling. Monitor electrolytes closely to avoid SIA, DH, or diabetes insipidus, both common after neurosurgery. Postoperative care also involves analgesia, seizure prevention, and early mobilization to prevent complications like deep vein thrombosis. Dr. Thomas is managing a 65-year-old woman scheduled for a total knee replacement. The patient has a history of osteoarthritis and reports significant pain despite oral NSAIDs. She is concerned about the use of opioids. How should Dr. Thomas design a multimodal analgesia plan for this patient, minimizing opioid use? Answer: Dr. Thomas should create a multimodal pain management strategy that reduces opioid reliance while ensuring effective pain relief. Preoperative acetaminophen and NSAIDs, e.g., celecoxib, can be used to manage inflammation and pain. Gabapentin or pregabalin for neuropathic pain control, reducing central sensitization. Intraoperative regional anesthesia such as an adductor canal block or periarticular injection with local anesthetics, bupivacaine, will provide targeted analgesia without affecting motor function. Use TIVA, total intravenous anesthesia, with agents like propofol to avoid the hyperalgesic effects of volatile anesthetics. Postoperative NSAIDs and acetaminophen for ongoing inflammation management. Consider cryotherapy and physical therapy for additional relief. What are the key considerations for using somatosensory evoked potentials (SEPs) during spine surgery? Answer: SSE. PS are used to monitor the sensory pathways during spine surgery to detect potential spinal cord injury. Key considerations include Anesthetic effects. Volatile anesthetics can depress SSE, P amplitude and increase latency. TIVA with propofol or remifentanil is preferred because they have less impact on SSE, P signals. Muscle relaxants should be avoided because they interfere with motor evoked potentials MEPS. Electrode placement. Proper placement of stimulating and recording electrodes is essential for accurate monitoring. Ensure that electrical interference is minimized during surgery to avoid false readings. Baseline comparison. Continuously monitor baseline SSE, P values before and after any surgical manipulation. Significant changes in amplitude, 50% reduction, or latency, 10% increase can indicate spinal cord injury. Intervention. If significant changes in SSE, PS are noted, immediate interventions such as reducing traction or restoring blood pressure should be considered. SSE, PS provide real-time feedback, allowing for prompt detection of spinal cord compromise. Explain the challenges of airway management in a patient with cervical spine instability and the preferred techniques to minimize risk. Answer: managing the airway in patients with cervical spine instability is challenging due to the risk of exacerbating spinal cord injury or causing neurological deficits. Challenges include limited neck mobility. Traditional intubation techniques may not be feasible due to restricted neck movement. Risk of spinal cord damage. Any manipulation of the head and neck can worsen instability or lead to neurological injury. Preferred techniques: manual inline stabilization mills. This technique involves a team member stabilizing the cervical spine while the other performs the intubation. Fiber optic intubation, ideally performed while the patient is awake to minimize cervical movement. Fiber optic guidance allows visualization of the airway while maintaining spinal stability. Video laryngoscopy. This method provides a clear view of the airway without significant head movement. Avoiding neck extension. Keep the head and neck in a neutral position to avoid compromising the spine. Describe the role of peripheral and central sensitization in acute pain. Answer: acute pain results from activation of nociceptors at the site of injury, but it is influenced by two key mechanisms: peripheral sensitization and central sensitization. Peripheral sensitization occurs when inflammatory mediators e.g. bradykinin, prostaglandins, released at the injury site lower the threshold of nociceptors. This makes the pain response more intense and prolonged. Central sensitization involves increased excitability of dorsal horn neurons in the spinal cord due to prolonged or intense pain. This leads to amplified pain perception and hyperalgesia, increased sensitivity to pain. Both forms of sensitization contribute to the transition from acute to chronic pain. Preventing these processes is key in managing acute pain and preventing its chronic progression. What are the indications and risks of epidural steroid injections for chronic back pain? Answer: indications: radicular pain from herniated discs or spinal stenosis, chronic low back pain that does not respond to conservative management, sciatica or pain that radiates along the leg, risks infection at the injection site, dural puncture leading to headaches, spinal cord injury in rare cases, systemic side effects such as increased blood sugar or hypertension due to the steroid. Nerve damage if injected improperly. Epidural steroid injections can provide significant pain relief, but they must be used cautiously, particularly in patients with compromised immune systems or those prone to bleeding. Compare the mechanisms of action of gabapentinoids and tricyclic antidepressants TCAS in chronic pain management. Answer: both gabapentinoids and TC are used to manage chronic pain but act through different mechanisms. Gabapentinoids, gabapentin, pregabalin. These drugs bind to the D subunit of voltage-gated calcium channels, reducing calcium influx and decreasing the release of excitatory neurotransmitters. This dampens central sensitization and relieves neuropathic pain. Tricyclic antidepressants TCAS, TC inhibit the reuptake of norepinephrine and serotonin, enhancing their effects in the central nervous system. This modulation of neurotransmitter levels can help alleviate pain, especially in conditions like diabetic neuropathy and post-herpetic neuralgia. Both drug classes are effective for neuropathic pain but have different side effect profiles, with TC is often associated with anticholinergic effects, dry mouth, constipation, while gabapentinoids may cause dizziness or sedation. What are the key considerations when administering anesthesia to an obese patient undergoing surgery? Answer: anesthesia for obese patients requires careful planning to address both physiological and technical challenges. Airway management. Obesity increases the risk of difficult intubation due to a short, thick neck and excess soft tissue. Fiber optic intubation or video laryngoscopy may be necessary. Ventilation. The obesity hypoventilation syndrome and restricted chest wall movement make mechanical ventilation challenging. Ensure adequate pre-oxygenation and consider the use of positive pressure ventilation if necessary. Drug dosing. Doses of anesthetic drugs should be adjusted based on lean body mass to avoid overdose. Propofol is often preferred for induction due to its rapid onset and short duration. Postoperative care. Obese patients are at high risk for postoperative atelectasis, hypoxia, and DVT. Close monitoring of oxygenation and early mobilization is essential. How should blood glucose be managed in the perioperative period for a diabetic patient undergoing surgery? Answer: perioperative blood glucose management is critical to avoid complications such as infection and delayed healing. Preoperative: optimize blood glucose control before surgery. Encourage patients to fast for at least 8 hours, but adjust insulin therapy accordingly. For insulin-dependent diabetics, administer long-acting insulin as prescribed but consider adjusting doses. Intraoperative: monitor blood glucose every 1-2 hours. Aim to maintain levels between 140-180 DL. Use intravenous insulin infusions for tight control, adjusting based on glucose levels. Postoperative: continue blood glucose monitoring and adjust insulin doses to prevent both hypoglycemia and hypoglycemia. Maintaining strict glucose control can reduce the risk of postoperative infections and promote healing. Explain the physiological changes in respiratory mechanics during general anesthesia and their implications for mechanical ventilation. Answer: general anesthesia affects the respiratory system by causing reduced functional residual capacity (FRC), relaxation of the diaphragm and intercostal muscles, decreases lung volume, leading to reduced oxygen reserves. Alter compliance. Both lung and chest wall compliance decrease under anesthesia, making ventilation less efficient. Impaired gas exchange. Atelectasis is a common occurrence, reduces surface area for gas exchange and increases ventilation perfusion mismatch. Depressed respiratory drive. Anesthetics suppress the medullary centers, controlling respiration, necessitating mechanical ventilation. Implications for ventilation: adjust tidal volumes to 6-8 mag of predicted body weight to minimize barotrauma. Apply positive end expiratory pressure PEEP to prevent atelectasis. Regularly monitor arterial blood gases (AGs) to ensure adequate oxygenation and ventilation. How does hypothyroidism impact anesthesia management, and what precautions should a CRNA take? Answer: impacts on anesthesia. Increased metabolic rate elevates oxygen consumption and carbon dioxide production. Cardiovascular risks. Patients are prone to tachycardia, arrhythmias, and hypertension. Thyroid storm. Life-threatening condition triggered by stress or surgery. Precautions: achieve euthyroid state preoperatively with antithyroid medications e.g. metamazole and beta blockers. Avoid drugs that increase sympathetic activity such as ketamine. Monitor core temperature and cardiovascular status intraoperatively. Be prepared for rapid treatment of thyroid storm using IV beta blockers, cooling measures, and hydrocortisone. Relevant guidelines. The American Thyroid Association (OTA) provides detailed protocols for perioperative thyroid management. Mr. Lee, a 65-year-old patient with hypertension, is scheduled for surgery. He takes enalapril, a long-acting ACE inhibitor. What are the anesthetic considerations regarding his medication? Answer: ACE inhibitors like enalapril can cause intraoperative hypotension, particularly after induction of anesthesia. Recommendations: preoperative evaluation. Assess the need to hold ACE inhibitors 24 hours before surgery. Evidence suggests withholding may reduce hypotensive episodes. Intraoperative management. Be prepared to treat hypotension with vasopressors like phenylephrine or norepinephrine. Postoperative monitoring. Resume ACE inhibitors cautiously, monitoring for rebound hypertension. Relevant guidelines. European Society of Anesthesiology and Intensive Care (ESAIC) advises individualized decisions based on surgical risk and patient comorbidities. Describe the effects of volatile anesthetics on cerebral blood flow (CBF) and intracranial pressure. Answer: volatile anesthetics e.g. isoflurane, sevoflurane cause CBF increase due to cerebral vasodilation, which may exacerbate intracranial hypertension in patients with compromised intracranial compliance. Reduced cerebral metabolic rate of oxygen (CRO). This neuroprotective effect may counterbalance the increased CBF. Clinical considerations: use lower concentrations to minimize ICP elevation. Combine with IV anesthetics e.g. propofol to mitigate the increase in ICP. Monitor ICP closely in patients with traumatic brain injuries or tumors. Relevant guidelines. Brain Trauma Foundation guidelines recommend targeting CPP, cerebral perfusion pressure, over ICP alone to optimize outcomes. What are the mechanisms of action for common antiemetic drugs used in anesthesia, and how do they help prevent postoperative nausea and vomiting (PONV)? Answer: antiemetic drugs used in anesthesia target specific receptors involved in the vomiting reflex. Ondansetron 5-AT antagonist blocks serotonin and 5-AT receptors in the chemoreceptor triggers in CTZ and gastrointestinal tract, preventing nausea and vomiting triggered by anesthesia. Dexamethasone, corticosteroid. The exact mechanism is unclear, but it likely involves reducing inflammation and enhancing the effectiveness of other antiemetics. Metoclopramide, dopamine antagonist, acts by blocking dopamine receptors in the CTZ, improving gastric motility and preventing nausea. Aprepitant NK antagonist blocks neurokinin-1 receptors in the CTZ, preventing nausea from substance P release. Scopolamine anticholinergic inhibits muscarinic receptors in the vestibular system, preventing motion-induced nausea. Management strategies: a combination of drugs e.g. ondansetron plus dexamethasone is often used for high-risk patients to enhance PONV prophylaxis. Scopolamine patches may be useful for patients at high risk due to motion sickness or vestibular disturbances. Relevant guidelines: ASAP-ONV guidelines emphasize risk stratification and multimodal prevention strategies to minimize PONV in high-risk surgical patients. Explain the mechanism of action of depolarizing and non-depolarizing neuromuscular blocking agents (NMBAS) and describe the key differences in their clinical use during anesthesia. Answer: neuromuscular blocking agents are essential in anesthesia to induce muscle relaxation for intubation and surgery. These agents work by interfering with the transmission of nerve impulses to muscles at the neuromuscular junction. Depolarizing NMB is e.g. succinylcholine. Mechanism: succinylcholine binds to acetylcholine receptors on the motor end plate and causes continuous depolarization of the muscle membrane. This initial depolarization leads to muscle fasciculations followed by paralysis as the membrane cannot repolarize. Clinical use: succinylcholine is used for rapid sequence intubation due to its quick onset 30-60 seconds and short duration 5-10 minutes. It is contraindicated in hyperkalemia, malignant hypothermia, and muscular dystrophies. Non-depolarizing NMB is e.g. ricuronium, vecuronium. Mechanism: these agents competitively inhibit acetylcholine at the neuromuscular junction, blocking the binding of acetylcholine to its receptor without depolarizing the membrane. This results in muscle paralysis. Clinical use: non-depolarizing agents have a longer duration of action, 30-90 minutes, compared to succinylcholine. They are used for routine intubation and surgical procedures. Reversal agents like neostigmine or Sugamade X are commonly used to reverse the effects after surgery. Key differences: onset and duration. Succinylcholine has a fast onset and short duration, making it ideal for rapid sequence induction, while non-depolarizing agents have slower onset but longer duration. Adverse effects: succinylcholine can cause hyperkalemia and malignant hypothermia, whereas non-depolarizing agents are generally safer in these regards but may cause prolonged paralysis if not reversed appropriately. How should the anesthesia provider manage a diabetic patient's blood glucose levels during surgery, and what are the key risks associated with poor glycemic control in the perioperative period? Answer: perioperative management of diabetes is essential to prevent complications such as hypoglycemia, infection, and poor wound healing. The goal is to maintain tight glucose control while avoiding extremes. Preoperative management medications. For insulin-dependent diabetics, rapid-acting insulin can be administered the morning of surgery with adjustments based on the patient's blood glucose levels. Oral hypoglycemics should generally be withheld on the day of surgery to prevent hypoglycemia. Blood glucose monitoring. Blood glucose should be monitored frequently every 1-2 hours in the perioperative period. A target blood glucose of 140/1A or ADL is recommended by the American Diabetes Association (ADA) to prevent complications. Intraoperative management. Insulin and glucose infusion. In cases of poorly controlled diabetes or long surgeries, insulin infusions combined with glucose should be used to maintain stable blood glucose levels. Regular or rapid-acting insulin can be infused at low rates, e.g. 1-2 unit gel. Avoiding hypoglycemia. Anesthesia providers should monitor glucose levels carefully to prevent hypoglycemia, which may cause altered consciousness, cardiac arrhythmias, and brain damage. Postoperative management. Ongoing monitoring. Postoperative glucose monitoring should continue, and insulin doses should be adjusted based on the patient's eating habits and stress levels. Considerations for healing. Hypoglycemia can impair wound healing, increase the risk of infection, and lead to diabetic ketoacidosis (DKA). Tight glucose control with targets of 100 AMDL is important in the postoperative period. Risks of poor glycemic control. Hypoglycemia can lead to increased infection rates, delayed wound healing, and diabetic ketoacidosis (DKA). Hypoglycemia can lead to cardiac arrhythmias, neurological dysfunction, and severe metabolic imbalances. Mrs. Thompson is a 55-year-old woman with a history of obstructive sleep apnea (OSA) who is undergoing an elective cholecystectomy. During the preoperative assessment, she reports excessive daytime sleepiness and difficulty maintaining adequate ventilation during the night. What strategies should the anesthesia provider consider to manage her OSA during the perioperative period? Answer: in managing a patient with obstructive sleep apnea (OSA) like Mrs. Thompson during surgery, special attention must be given to airway management, ventilation, and analgesia. Preoperative: the anesthesia provider should assess the severity of OSA, consider preoperative polysomnography or clinical screening to determine the risk of complications. Ensure that Mrs. Thompson's CPAP continuous positive airway pressure therapy is continued postoperatively if she uses it at home. Intraoperative, airway management is crucial. Use of a supraglottic airway or endotracheal tube should be considered to maintain airway patency. Since sedative agents may exacerbate airway obstruction, opioid-sparing strategies such as regional anesthesia should be utilized to minimize respiratory depression. Postoperative, close monitoring in the recovery area is essential to prevent airway obstruction and hypoxemia. Supplemental oxygen or non-invasive ventilation e.g. BiPAP may be required. Additionally, use of multimodal analgesia avoiding excess opioids will help reduce the risk of respiratory depression and improve recovery outcomes. What are the key physiological differences between general and local anesthesia, and how do these differences influence the selection for various surgical procedures? Answer: general anesthesia induces a global loss of consciousness and muscle relaxation achieved by affecting the central nervous system (CNS) primarily through drugs acting on GABA receptors e.g. propofol, or NMDA receptors e.g. ketamine. This leads to systemic depression of the respiratory and cardiovascular systems, requiring airway management and ventilation support. It is preferred for major surgeries e.g. abdominal, cardiac, where complete unconsciousness and immobility are required. Local anesthesia, on the other hand, works by blocking nerve conduction at the site of application, usually via sodium channel inhibition. It does not affect the CNS, allowing patients to remain conscious. This anesthesia is often used for minor surgeries e.g. dental work, skin excisions where only a localized area needs to be anesthetized without impacting overall physiological function. The selection between the two depends on the surgical complexity, patient preference, and underlying health conditions. General anesthesia is necessary for invasive procedures, while local anesthesia is ideal for outpatient or less invasive surgeries where the patient can tolerate being awake. Mr. Roberts, a 45-year-old male with a history of hypertension and diabetes, is scheduled for elective knee replacement surgery. During the preoperative assessment, his blood pressure is elevated at 106/95 mmHg and his blood glucose is 108 mg/dL. What should the anesthesia provider focus on in managing this patient's comorbid conditions during the perioperative period? Answer: for Mr. Roberts, managing his hypertension and diabetes during the perioperative period is critical to minimize risks and ensure a smooth recovery. Hypertension, preoperative management. Control blood pressure aiming for a target of 104/9 mmHg. Ensure the patient continues his antihypertensive medications up to the day of surgery. If his blood pressure remains high, consider adjusting medication. Intraoperative management. Monitor for any blood pressure fluctuations during anesthesia induction and throughout surgery. Use vasopressors like phenylephrine if needed to stabilize blood pressure and prevent complications such as stroke or cardiac events. Postoperative management. Continue antihypertensive treatment and monitor for postoperative hypertension due to stress or pain. Diabetes. Preoperative management. Optimize blood glucose control, aiming for a fasting glucose of 100, 14 or 80 dl. Adjust insulin doses as needed based on preoperative glucose levels. Intraoperative management. Monitor blood glucose levels regularly and use insulin infusions to maintain euglycemia 140, 180 or 80 dl during surgery. Postoperative management. Keep blood glucose stable to prevent wound infections and promote healing. Effective management of these comorbidities reduces the risk of infection, poor wound healing, and cardiovascular complications.